Our webinar today will be led by Brad Gingerich. He is a healthcare executive with over 15 years of managed care and rev cycle operations expertise. And he really specializes in contract negotiations, strategic solutions, helping orgs maximize their revenue. And Brad, I will let you take it away.
Good afternoon, everyone. Thank you for the opportunity today. So as we get going here, just first of all, I don't use this as a sales opportunity. I'm not here to sell anything. I'm hopeful to educate and encourage my provider colleagues here to take the challenging steps to try to level the playing field against payers, and that at times can be contentious despite the goal of removing friction. And my goal again here is really to try to get our community at large to recognize some of these opportunities and to really stand up and push back against these payers. Rising tides, of course, lift all ships. And if we are able to do this collectively as an industry, I believe we'll be able to reshape the balance in some of these payer relations and get back to a more neutral standing. So just by way of background, again, my name is Brad Gingerich. I've been at this for over 18 years now. My career has been spent in the payer contracting and negotiation space, primarily the entire time. I have focus in all aspects of revenue cycle, hospital operations, management, turnaround as well. But really my core focus is in the payer space. I really enjoy that. That's what gives me a lot of purpose, and more these days than ever. It really feels like I'm on the right side of things here as I try to help our clients, community hospitals, and health systems really secure their financial future and solvency to be able to deliver on their missions. By way of Ensemble, the entity that I'm representing today, that really gives me the opportunity to be able to carry that mission. We are rather large. We represent over 37 billion in net patient revenue. We have clients in nearly all states. Through that reach, we deal with and manage over 6,000 unique managed care contracts, over 100 payer provider negotiations my team and I support. And so I say that just really to say we've got quite a bit of experience and reach in this space. We like to think we've seen just about every contract there is out there, every iteration. We've gone through the battles with the payers, and really all of them. I've spent time out of network and network. I've negotiated with all the large payers, been out of network with all the large payers as well. So really our experience is diverse. It runs really the entire gamut with payers and payer relations. Beyond just contracting, we also focus a lot on payer performance, dispute resolutions, and really ensuring those contracts are followed. So that's what me and my team do for our clients. Ensemble, we are a complete end-to-end revenue cycle outsourcing partner with many health systems across the country. What we do on the payer strategy side, we provide this as a value-added service to our clients as a means to, of course, liquidate AR and help drive their contracting outcomes. Today's presentation, I'm really going to focus on two parts. First, we're going to start with just a bit of a state of the union on where healthcare is today, particularly in the hospital and the contracting space, some of the financial pressures on hospitals, really just to set the tone for why managed care contracting is so important and the pressures on it today. And then from there, we'll move into some actual tactics, strategies, and ways to be successful in the negotiation process. So first, as we jump into it, none of this is going to be as a surprise to anyone here. Really post-COVID, healthcare providers have been under a lot of pressure, significant pressure, particularly in the expense side. Now, revenues haven't moved to keep pace with the expense growth. Really post-COVID, we experienced this significantly, particularly through contract labor, expenses, inflation. Everything was a huge constraint. We're starting to move out of it today, but those payer contracts never kept pace with this. We're actually expecting by 2027 for expenses to exceed revenues by 15%. That actually leaves, that's going to leave a $200 billion gap if we're not able to close this. In order to close it to break even, that would require a 5 to 8% increase each year from all payers. So I just want to pause there for a second and emphasize that that's all payers, and that's 5 to 8% increase each year. So that suggests you would need a 5 to 8% increase from your governmental payers, from your managed Medicare, your managed Medicaid, and as you all know, as I know, that's just not reasonable. You're not going to see those sorts of increases from a lot of the governmental payers, and as a result, it's going to put even more pressure on the commercial negotiations, which for a managed care professional such as myself, we're finally having our day in the sun, as it were. It puts more focus and more emphasis on what we do in the negotiation process. Definitely makes it more important to a hospital solvency, but at the same time, it puts even more pressure on the process as a whole. And as that pressure mounts, hospitals are forced to make some challenging decisions. So aside from that, I just covered what we need to achieve in the negotiation process and what we need to actually accomplish. But that's only half the battle. The other half is actually then getting paid on those contracts. So assuming you're very successful in your negotiation and you achieve those 5 to 8% increases that we were striving for on the prior slide, still we're not materializing all that revenue. Insurers are making it harder and harder to collect. And again, really, this started to ramp up post-COVID and hasn't slowed down since. We've seen a 5% increase in AR greater than 90%, 67% increase in prior auth denials. We continue to see increases in callbacks through audits, and it's just continues to get worse each year. I know we all see this in the amount that providers invest just in trying to collect on these dollars. So how we get to this point? Well, AI, we talk an awful lot about. It's the very exciting new topic. However, we in the provider space, I hate to say, we're a little late to the game here. So what we've seen in the prior slide was showing the amount of denials and the challenges to get paid. This is by and large through the utilization of AI, but on the payer side. So again, they beat us to the punch in terms of really standing up AI tools as a means to effectively deny claims. It's largely done under the guise of payment integrity, which sounds very noble, but at the end of the day, it's just resulting in more and more claim denials for providers. And mind you, the majority of these claim denials, particularly RFI denials, we overturn these denials greater than 90% of the time with no impact to payment. So what that actually results in is just a delay in payment and an increase in administrative costs and burden to get there. So while AI shows a lot of promise, particularly on the provider side, so far we've not kept pace with the tools that the payers are bringing to market.
And Brad, I actually may chime in here a second just to ask quickly, if folks are making investments or even exploring AI to assist with their rev cycle functions, would love to hear from the provider side, whether in the chat or come off mute to talk about it. Because I know at the Academy here, we've done plenty of research, just reiterating what you said of, there are these challenges on the provider end. They see the potential for AI to assist, but, that uptake hasn't exactly kept up. So encourage any thoughts here to bring that provider's perspective.
I'm gonna take the silence. There's probably not a whole lot of investment going on here. I'm sure providers are thinking of it and looking for entryways. What I can tell you is Ensemble has made significant investment in this space and continue to. Obviously, with our role here, we need to combat these, and so I kind of jokingly think of it as Terminator. We've got bots fighting bots. But really, that's what it's coming to now to be able to keep pace just with the scale and the speed that the payers are denying. We need to be able to write appeals just as quickly, but with the same level of quality. We need to be able to ingest all of these denials real time and reverse engineer what the actual levers are that are causing them to deny and trip up in the first place. And so AI has a ton of use cases for us on the RCM space. And Ensemble is, again, making significant investment in that. But I think we may be a bit unique in that, in as much as we are in an economic position to be able to do so, where many healthcare providers, the cost of entry into AI can
Hmm.
be so that's where it can sometimes be out of reach for community health systems to try to stand up some of these sophisticated tools at the level that the payers are. And so I'm not
Hmm.
surprised that we didn't hear an uproar of people.
Well, I think Matt, you have your hand up.
I do. Matt Swafford at St. Charles Health System. One of the one of the things that I think is important for when you ask a question like this is it's the premise is that arming up is what we need to do in an ever escalating set of tools. And and the concern I have about the conversation with payers, and we've been driving this conversation very specifically here in our community focused system here in Central Oregon, and we are the sole community provider, so our situation is a little bit unique. And the premise is that patients and providers are that we serve and employ are expecting that we just fight. And while we are doing that, adding more tools that just have bots, you know, fighting with other bots further embeds waste in the system and additional cost. Perhaps it's more efficient to use artificial intelligence, remains to be fully fleshed out, I think. But the point is that if in 2022 you had 46 million prior authorizations in Medicare Advantage alone, or in Medicare alone, and 7 million of them were appealed, and 80% of those, or over 80% of those, were overturned. If you extrapolate that, there's an extraordinary amount of waste that we are then buying technology or entering into service contracts to embed in our back and forth. And and it's much more difficult, I think, to have bespoke conversations around what are the quality guidelines that we use by procedural area that determine whether a provider is their outcomes warrant prior authorizations. And if we're actually embedding so much waste in our system, we're just exchanging what could be paper and phone calls and time for joules of energy and silicon chips. So one of the things that I get concerned about is that if we just look at it as arming up only, and that's the total of the conversation, we're missing an opportunity to highlight a substantial amount of waste in both provider and payer resources fighting about something that is ultimately screwing the patients and the providers of care. So I'm a little concerned that if it's just focused on who's got the highest technology, which is part of it, we're missing the greater point and the greater conflict, which however we approach it, patients are pissed off and we need to recognize that.
Yeah, and I think, man, I think that's a great point. And first of all, I'm very familiar with what your organization is doing and the approach you take in the contracting, and it's very impressive and novel. I agree with the comments that you just made, and the bots fighting bots are one tool. I 100% agree with you. The focus where we're trying to move this upstream to the point I think you're focused on here is particularly in the instance where we're jumping through all these hoops, we're accruing all this administrative burden and cost, and it's to no avail. The payer's not even benefiting. And so a lot of times what we see is through the third-party audit firms who the payers will stand up on a contingency basis. It's of no cost to the payer to be able to just unleash these entities on providers. And now we're providing medical records and looking to defend our claims all throughout. But at the end of the day, there's no impact, there's no benefit to the payer because there's by and large no findings on a lot of these audits. But also there's no cost to the payer either because they're engaging a third party on contingency. And so anytime they do have a win, it's found money. And so with that premise in mind, I view the ability to appeal and defend audits at scale and doing it in a way that is extremely cost effective shifts some of this back to the payer in as much as there is a cost of business to them defending the appeals, which they will have to respond to. And so it almost creates a punitive opportunity to use appeals in a punitive manner. So that way there is a cost associated with the denial. Otherwise, the payers have minimal cost in that regard. But secondly, using the AI data to go back to the payers and demonstrate that there is no opportunity here. When you audit this DRG, 100% of the time the claim is paid and paid in full and there's no impact to payment. Let's exclude this from the audit list entirely. I just don't want to see any denials for medical record requests related to this DRG anymore, because historically it's always proven fruitless for you and it's costing me money. And the reason I have to take such an aggressive stance in these negotiations and secure so much additional revenue is because it costs money to defend these appeals, which have no benefit to you. And so I think it's twofold. It's one, we need to be able to respond with appeals in a way that is cost effective for us and are quality appeals that the payers are obligated to respond to. And so that way there's a cost to their denial, and as much as they have to put together a strong response. But secondly, using that data to do, which I think is really at the vein of your comment, which is let's eliminate all this nonsense in the first place. Let's eliminate the waste and the administrative burden by just jumping through hoops to get to where we're going to end anyways. So I think AI is a tool to help communicate that information, because now we can ingest large data to be able to show statistically there's no relevant reason for you to even be subjecting these particular services. So to your point, from a clinical outcome standpoint, AI can lend itself to that as well. Once you know who the providers are from a quality standpoint, then why should they ever be questioned? Why should they? Yeah, why can't we assume that they're innocent instead of them having to prove their innocence every time they write an order? So hopefully that addresses the question, or at least dovetails in with the comment.
Helpful, Brad. Thank you.
And this kind of goes right into what we were just talking about. So it's costing more and more ever to collect. 10% of every dollar collected is spent on actually collecting that dollar. That's 380 billion annually spent just to collect the revenue. No other industry can your customers really get away with that. No other industry can provide these interest-free loans to them and allow them to just delay payment over and over until you satisfy their conditions for payment long after the services have been rendered. It's the complexity is growing every day. I mean, we track and monitor 180 plus payer changes that are issued daily. That's really across all payers that we interact with, across all of our clients. So that scale is very overwhelming. A little different in the individual health system when you consider just the individual payers you're dealing with. But it still demonstrates that these are changing every single day. And in order to stay in front of every payer change, you need to have a dedicated team, which of course comes at an expense, to be able to stay in front of these ever-changing policies, which of course live outside of the managed care contract. They live in the provider manuals, which are subject to change routinely. And it is a growing issue, and why we need to drive or command such high rates of negotiations, just putting more pressure on it. Because once you again achieve the contract, you're still going to spend so much time and resources just trying to see that contract pay out. So just effectively a recap, hospital margins, this is just at national averages here, 4.7%. Again, the expense increase was 18% from 19 to 2022. 2023 was another 10% increase. And then ultimately, historically, managed care contracts for the longest time, we were seeing your standard COLA CPI increases, 3.5% thereabouts. Once the payers actually implement all their denials, all their UN downgrades, et cetera, you effectively historically we're seeing a 1 to 3% increase net at the end of the day. Obviously, the math here does not hold up and is not sustainable at those historical trends. And so really, through the managed care process, negotiation process, we're going to have to be able to achieve better contracting outcomes. As I mentioned before, there's limited return that you can really reasonably expect in an MA contract. You're not going to see commercial rates from MA payers, likewise from Medicaid, managed Medicaid. And so it's right or wrong, it's putting more focus and more burden on the commercial payers, which, as we all also know, are by and large self-funded employers. That's a lot of thoughts on that. So jumping into strategy though, I'm really going to focus on four key areas here. This is very high level, but I'm happy to kind of go into the weeds on any of this stuff. So again, as mentioned before, by all means, jump in, interrupt with any questions or any specific, well, not too specific, but any actual nuanced conversation you want, by all means, I love to talk about this stuff. So jumping right in first, set the tone. So what we're seeing more and more, maybe your organizations have done this, maybe you're on the sidelines watching this play out, but more and more negotiations are spilling into the public arena. You're seeing, in fact, payers be the first one out there in an attempt to control the narrative and trying to run to the press and talk about how egregious it is that the provider is asking for this very aggressive increase, and the providers are the responsible for why healthcare is so expensive. And that's really the narrative that you see come out quite often these days from the payer. When we say set the tone, what that means is really need to consider being the first to act here. Get out there first and set the narrative. Communicate with your stakeholders. Let the community at large know, particularly if it's a large payer negotiation, if it's your largest payer, if they have a diversified offering. So if they're offering commercial care and CAID, if there's a lot of different patients potentially impacted by this, you need to consider getting out there early and setting the tone. And again, controlling the narrative and the message, and that being that your health system is there for the community. It provides a needed resource for the community. They're the ones that are open at 2 a.m. on a Sunday morning at the ER. No, it's not the insurance company, and all that takes money, and it takes investment to be able to sustain this. And let the community know that's the reason you're taking on this challenging fight. Let them know that you require their support in this process. Let them know what they're going to anticipate in terms of some of the communications coming out, what the payers are going to say, and really setting the expectation with your community that you're making these hard choices and these challenging decisions because you're concerned about the long-term health of the community and the solvency of their health system. And so by getting the community on board, we found that is very powerful. Your community by and large supports the health system. We as providers benefit from having that favorable sentiment compared to the insurance company, obviously today more than ever. And so getting out there and really trying to harness that and get your community to rally around you in a negotiation is very powerful. And part of that is explaining that you're seeking an agreement on common sense fair rates. These are rates that are required to keep the hospital doors open. I mean, revenue cycle is so complex. The hospital financial economics is so complex, has a lot to do with payer mix, of course, service mix, everything. That's hard to break down into bite-sized pieces for the community to understand, but you do need to make it clear to them that this is to reinvest in the infrastructure or to keep systems running. This is it's not a matter of greed. By and large, most health systems are nonprofit. I mean, these are not proceeds that people are taking home with them at the end of the day. This is what allows charitable endeavors. This is what allows us as providers have thriving charity care departments, things of that nature. And so letting the community know what those funds are for is important. And then also, it's not about one payer. Really, your negotiation is all encompassing in the sense that, well, let me say your negotiation strategy is all encompassing. And this one payer that happens to be in the spotlight that you're negotiating with, it's just their time in the sense that the negotiation has come around, but you're effectively trying to fit them in to where they fit in a broader competitive landscape. And we'll get to that in the next page. So parity, analyzing parity, rate parity. This can take a lot of different forms when we talk about parity. So what I have on screen here specifically is internal rate parity in terms of comparing your payers, like payers. So in this case, just commercially insured, against each other and effectively evaluating their parity in relation to their size. And so yield being what they're actually reimbursing in this case as a percent, or excuse me, operating margin in relation to yield being their size in the market, operating margin being how much in relation to their expenses. And so it stands to reason that your larger payers are going to have a better discount, your smaller payers equally, really economies of scale. So a few things that kind of jump out here is you see payer B is one of the smallest payers and also has one of the best rates from the payer perspective. So that's not only creates an opportunity where they're are out of parity, they're effectively getting a better discount. The largest payer here being payer A, by size of the actual circle, you can see that they are getting a worse shake than payer B, but just by their total size, scale, purchasing power, you would expect them to get a slightly better competitive rate. That's an important concept, though, to spend some time on. We are not interested, just generally speaking, in making the big payers even bigger, right? We know that those with the largest market share can be the most challenging to deal with. In fact, there was a huge antitrust case just recently, class action, that really speaks to this. The larger the payer is, the more command they have in the negotiation process, the more they're able to drive down their negotiated rates, which is then further exacerbates their competitive advantage, making them yet even bigger. So as you approach parity, it's important to think and really mark this out over a multi-year trajectory. And knowing what escalations you have with all your various payers, you can effectively look at how this parity map might look in 3 years or in 4 years as the annual rate escalators that you may already have negotiated start to materialize, or aligning what your strategy is for certain payers. Because ideally, we want to try to compress these and get them as close as possible. So that way, again, in this example, payer A doesn't continue to get bigger and just cannibalize all of the market as a whole. So we have a bit of a responsibility in that in our negotiating process, which means, like payer D, you don't always necessarily have to go for the most you can, because then payer D just continues to get smaller and smaller. And so if their price per unit is so much greater than everyone else, well, that is a sunsetting opportunity as well, as they continue to diminish the market size. So an important component there is parity, but you can also use that in the negotiation process by showing the payer. So for example, payer B in the negotiation, there's no reason that they should have that rate right now. There's no reason they should reasonably expect to stay there. And so they really are going to have to be subject to a significant increase in this negotiation. Otherwise, you have to consider the tough decisions, which is potentially a termination. But so this here really is demonstrating internal parity. But when we say parity, though, we also can think about what pricing transparency has lent to the negotiation process. So while I don't have it shown on screen here, just take a moment to talk through it. You can also consider parity with competing health systems. And so as we all know, through the No Surprises Act and pricing transparency, hospitals are now obligated to post their contracted negotiated fee schedules. That creates an opportunity for us to go out and look at our competitors' websites and actually pull down their negotiated rates with other payers. And so it creates an opportunity for you to understand parity across your payers. So if you're dealing with a Blue Cross, you know exactly how the competing facility in the neighboring town compares in terms of a rate with that same Blue Cross. And then you can factor in all the things you need to factor, size of that organization, the service offerings, reputation, et cetera. But at least it gives you something else, a benchmark to compare and target for in negotiations. What I will tell you is that I've found it often falls on deaf ears when you go to payers and say you're paying the neighboring facility 20% more than us. And that's not appropriate. Obviously, you can afford that. We want that same rate. And then the payers say, sorry, thanks, but no thanks. And that's about as far as the conversation goes. However, what I have found the pricing transparency data to be very compelling is more so in controlling the public opinion, like we had mentioned before. The community is very interested to know that the insurance company you're negotiating with has agreed to the rates you're seeking with other providers, particularly if that provider doesn't have the same reputation as your facility. That can be very compelling in the court of public opinion. And so as you think of additional ways to leverage transparency data, that may be one to consider beyond just bringing it to the payer and showing them how you're underpaid relative to the competitors. They already know that. They already know how they're paying all the providers, but the community doesn't know that. And so that can be very compelling as well. Before I jump and move on, I just want to give anyone an opportunity here to interrupt me and ask any questions.
We do have one question in the chat. Katie, I'm just going to read this out. How do you debate the smaller payers when they say we can't sell in your market unless we have rate parity with XYZ payers and they expect similar rates?
Yeah, so I've seen that accomplished in different ways. Yeah, so we spent, and that's a great question, by the way. So we spent some time on the prior slides talking about the administrative burdens and costs. Well, I'll go to a smaller payer and say, make it easy on me. It's not all about the rates. We invest so much time in just trying to get paid. Let's figure out ways to simplify things, simplify the managed care contract, simplify the administrative burden. You know, what do we have to do operationally? Claim subject to authorization, all these sorts of things. There's other ways to, I think, compel us to maybe look past rates in relation to parity. So like how a payer B could become a payer B, make it easy on us to do business. That would be one way to do it. That would resonate with me. And I would certainly lean into that. I would structure it all contractually though. I would limit the amount of first pass denials, different things like that. Try to put caps around AR, try to implement formal side-by-side work down sessions if AR grows to a certain rate. So really have the payer have some skin in the game in terms of ensuring the AR and the RCM process. Those are all things that I think would be reasonable and justifiable to give a potential rate concession in exchange for. Another thing that I've seen done as well, and to differing levels of success, is challenge the payer and call them on their bluff, if you will, and say, "We'll tell you what, you think that you can go out and sell new business at this new rate. We'll do a hybrid fee structure. And for all new business, new self-funded clients that you bring in, this will be the fee structure going forward." I've seen that done before. And in the case that comes to mind, that payer did not put up significant new business. So, you know, begs question, is it more of just a ruse from the payer that they're going to, if they had more competitive rates, they would land all this business? In that case, they did not. But I have seen providers say, all right, we'll do a carve-out fee schedule for any subsequent new business. Employer groups that are not already on this business, show me that you can actually grow your market share by virtue of these rates. So those are two ways to go. The latter, I think, is more complicated for us to administer, having multiple fee schedules. I'm not a huge fan of it, but it is a way to kind of call the payer's bluff. I'm more in line with, and this I think is kind of where Matt was going before too, is reward the good payers, reward the ones that make it effortless to do business with them and don't subject you to all the nonsense. That cut, you know, if it costs you 10% just to collect the dollars, well then if that goes away, that gives you 10% to work with in terms of rates. So that's how I would approach those payers, Katie.
Thank you, Brad.
And we have actually another interesting comment from Rebecca Phelps here. So with price transparency, payers have access to their competitors' rates. Have you seen where they're using that to reduce their rates?
Well, I've seen them make the ask, and I guess that's maybe the reason they give me the same answer when I come at them with that. To a yes or what, that would be my response to them. You're seeing more and more of that lately. There's one particular, I don't want to single anyone out, but there's one particular payer that is trying to enhance their competitive position, and they lately are coming out seeking effectively rate concessions from providers because they want to be in line with who is the pseudo favored nation today. So we're seeing a lot more of that come out where they are pulling down the transparency data to be able to say, look at how much, how much cheaper you are with them. And again, it's the same idea. Well, if you were as large as them and had the purchasing power, well, then you could command those same rates, but you don't. But yeah, also great question. Yeah, and they certainly are doing it or attempting to.
Great, thanks for that clarity.
So the next one, this is an area that I've seen in my career change in terms of how we go about payer contracting. So historically, it was somewhat siloed in a lot of ways, at least in my experiences. It was done with a negotiator, maybe an analyst, and the CFO is involved in it. And that was usually about it. And it didn't expand too much beyond that. Managed care negotiations were fairly routine. Again, expectations were pretty muted, 3-4% increases, run of the mill, just let contracts roll over a lot of times, just under the CPI increase, particularly percent of charge contracts. They don't even get touched, and you just try to grandfather them. But since then, really since around COVID, and as the managed care contracts have taken more of a kind of front and center for hospital revenue creation, it's become much more of a multifaceted team sport. And so the way we're finding the most success is really getting everyone involved and everyone involved early, and that provides a lot of benefits. So one of them is it builds consensus amongst the organization and leadership. And I say that because when you're in the heat of a negotiation and at kind of the closing end of it, which often is December 31st, midnight, and all the pressures are running high, it's going to be tempting for individuals to want to just concede and just be done with this thing. And the offer that's on the table is good enough. Let's just be done. It's the holidays. I don't want this hanging over my head. The payer's been aggressive in the press and calling into question everything from quality to the rates that we're seeking. I want to be done with it. And so being able to get everyone brought in early and invested in this really keeps everyone focused on that same goal. And so when those pressures start to come through, and they do, when the call comes to the CEO's office from someone very well placed, whether it's an insurance commissioner or a large self-funded employer or the governor's office, someone who has clout starts calling and trying to pressure, it really helps that everyone's already bought in, connected on this thing, and we're all working towards the same goal. So that way, you don't have a weak link, as it were, that might be subject to different pressures and want to just carve this deal off and get it done. It also allows you to cover everyone's bases and interests. I mean, as you work through it, you're going to contracting processes where you can have the potential to solve for all your issues, not all of them, but majority of them. So administrative burden, things like that. It's really through the negotiation process that you can get things effectively entered into the contract, codified as rule going forward. They won't do this type of denial, or they'll limit this type of denial. So getting all facets of operations involved, so where, say, you have authorization delays, where you have credentialing issues where they're not loading your physician rosters timely. Really trying to get every single stakeholder involved and have a voice in this, so you can tally all those items and go and try to solve for all of the negotiation process. And even if you can't solve for all of them, there's a give and take on everything. And so if you can't get agreement on one thing, you'll likely get a concession elsewhere for it. But this is where we deal with, under strategy, for example, under the negotiations, this is where, I was mentioning parity, and this is where public relations is going to get involved as well. And this is where the communications team can start to put the information out there about how the rates you're actually seeking are well in line with what this payer pays other facilities. And it's not a matter of asking for excessive rates, and you can get out there and control the narrative around quality. Some other things that can be done, and as I mentioned earlier, it's a very high level, and we can go to the weeds on this stuff, time permitting, but by pulling in all these groups, we can really leverage and consider all the different payer facets. So for example, if you're going through a diversified health plan that has a Medicare product, commercial product, Medicaid product, that creates a lot of opportunities during open enrollment as well. The insurance carriers, by and large, all their profits made on their Medicare Advantage business and their fully insured business. It's not the commercial business, right? And they're not even the ones paying the claims in the commercial business. That's just administrative fees, at least 80% of it. And so being able to leverage things such as their Medicare participation during a negotiation as a means to get outsized results on the commercial rate is very effective, particularly during open enrollment when the consumer is actually driving the decision making in terms of what plan they'll have next year. So that's where, again, through public relations and communicating with the community at large and with broker network, you can really start to compel the payers to try to resolve things sooner than later. And again, that's where typically you'll see an increase on the commercial rates, right or wrong, but that's how it works out. Of course, Medicare rates are pretty much frozen and pegged to Medicare, but then that's why we're at 2.5 times Medicare and all the commercial on average. But being able to really take this cross-functional approach allows you to go in and tease out leverage in every area that you have it, but also to make sure that you're covering for all of your needs in the negotiation process. And really everyone has a voice in it. And when the negotiations are the most strenuous, as it were, and going down to the wire, you really need to start thinking beyond the negotiation and the alternative, which is the potential that you're out of network. And so that also raises a lot of operational concerns. How are you going to handle patients, throughput in the health system? How do you handle a patient who's been admitted and then needs a subacute, which is not a medical emergency? There's no Surprise Act protections on those things. Really having a game plan for how to operationalize all that stuff and actually having those conversations candidly with the payer during the negotiation, having your actual operations team figure out a way to operationalize out of network with the payer really sends a different tone to the payer that effectively you're a take it or leave it where it stands right now. You're thinking beyond the negotiation and preparing for the eventuality that you will be out of network. And, historically, we always see everyone blink at the last hour and sign the contract. But when you start to have those conversations that are thinking beyond and focused on out of network time, it really changes the sentiment of the payer, and they take a very different approach and realize that this is mission critical and there's a good chance that this contract doesn't go their way. So that's just quickly kind of tip of the iceberg on all these, but really each of these bubbles goes into its whole kind of area of different strategies and opportunities. Just let me pause for any questions, but just in sensitive time here, let me keep rolling.
Yeah, Brad, I have a question here, but for the sake of time, I'll hold off, just flagging that I may circle back to this later.
Sure, and we're just about done here. So fourth, stay the course. So in this, and I find myself saying this more and more, but if you're getting that contract done early, you've probably left money on the table. And so this is just one real case study. This is over a 3-year escalation. So this wasn't just the year one rates, but this was a cumulative rates over 3 years. This is an actual negotiation back and forth. And what you see here is the health system client. So this is each offer in volley and how much the payer moved in reaction to each one. And what you really see is almost no significant movement from the payer until they get into December, which is the last month of the negotiation. In fact, the payer really, or the provider, is effectively negotiating against themselves with each concession in relation to the payer coming up. But again, what you find is the payer doesn't, and I have never seen them put their best and final out there anytime before, at least the last couple of days, if not the final day before the termination. Even then, oftentimes it still goes beyond the termination. The payer's going to ask for an extension. They almost always do, 30 days or something. If you don't agree to it, make them pay for it, because that's 30 days that you've just foregone an increase. But the point here is if you're thinking about putting your pen on paper and you still have another 30, 60 days to go, you have a ton of time left. It's like dog years in terms of negotiating how that last month plays out. Really, the volleys don't go back and forth in any aggressive manner until you really get close to that timeline. So use the clock in your benefit and understand that, there's not a huge urgency to even be making these responses so quick. We could have probably done without all of these and really started to do the significant back and forth, around December 22nd and just held firm until that point. But again, you're not going to see the best until tempers are kind of running at their peak, and that's always right before the contract falls. So my encouragement there is dig in. You go into this from the start, you know what you're targeting in terms of a rate increase. Don't expect to get anywhere near that till at least that final day, and take them the distance so you know that you're not leaving money on the table in that sense. Then just jump to some key takeaways, and then we can just open for some question dialogue there. So yeah, the first takeaway being the last one I just covered. So be patient. The payer's not going to move until you're close to termination. You really want to build all of your leverage up until that point. Almost even being aloof to the negotiation, starting to think beyond the negotiation, how to operate it in a network setting with that payer, focusing on open enrollment and communicating with the community at large. That really sends a shock to the payer that you are effectively packing up and moving on, and you're going to reward other payers who aren't as challenging, and reward them with your participation, which really, and again, familiar with some strategy you guys have employed, but I think that's a very very good way to go about this, is trying to put a premium back on the network, back on participation. We've gotten to the point where providers in general, we sign every managed care contract that shows up at our door. Every MA plan comes knocking before they even have lives, and they'll put a nice looking rate in front of us, and we'll sign the contract. And before you know it, you're contracted with every MA plan. There's no value to the participation. So by creating scarcity and selecting a few, particularly in the MA space, a few payers to partner with, and they get rewarded because they get the consolidated business and market share because they're the only contracted MA in town. But then you really hold the leverage, because now that contract, that participation has value to the payer, and you have the ability to take it away from them. So they have to continue to meet you where you're at to maintain their status as a participating provider. And so creating scarcity around network participation, I think, is a brilliant move, and Joseph, you gave me the leeway to go down a rabbit hole, which I did, because that's not so much on screen here. So thank you for that. But get creative. I guess it does fall under that. So with No Surprises Act, Medicare Advantage, open enrollment, same thing with managed Medicaid. A lot of those members, they can change plans mid-year for just cause, depending on the state and participation status. Termination, losing your PCP in many states qualifies as just cause. And so you can have outreach to patients, and you can actually start advising them of this, and you see real-time migration out to other managed Medicaid products. Payers take notice to all these things. And then we talked about this before in terms of preparing your leadership. It's the CEO's office who's going to feel the pressure the greatest, of course, but also that's where the well-placed phone calls are going to be landing. So when people in positions of power will be calling to lean on and influence the negotiation and try to get it done, and that's where your leadership really needs to be prepared for that. They need to have their talking points prepared so that they can stay the course, and leave it to the negotiating team to be able to get the deal done, and get a good deal done. So let me hold there, Joseph. Maybe we can have some dialogue here. However,
Yeah, definitely can. Thanks for the conversation, Brad. Really quick, everyone, I'm going to launch our feedback survey now, but do want folks to stay on the line and make the most of our kind of Q&A session here. And I'll give folks a second to, type in the chat with any questions they have, come off mute. but I might flag one comment we got or one question from Jason Williams around balancing fee-for-service rate increases with the terms of different value-based care models. So he's asking specifically about plans that have downside risk in total cost of care model and just how you balance that fee-for-service rate increase versus the terms of the VBC model.
Yeah, so I'll say this, try not to offend our physician practice colleagues on the call. Depending on how it's structured, what I'm always cautious about is being penny wise, pound foolish on that. So the value-based purchasing on a lot of those some of those risk deals, I don't want to assume I know your deal, but oftentimes we're splitting a shared dollar 50-50. And if that shared dollar is coming at the cost of a foregone rate increase, I'm sharing my opportunity for no good reason, I guess. And so what I would try to focus on is trying to neutralize for the contract increase on the provider side. So if you're being measured in terms of total spend for your population, I would seek to have some sort of neutralizing adjustment for the rate of increase just because of the provider where you refer to, their contract went up. That has nothing to do with the quality of care you're rendering. Your patients aren't any less healthy. They're not, in fact, seeking any more. You're not ordering more MRIs, just the cost of the MRI went up. And so I don't think the provider should be penalized by that. I think we could solve for it through the sophistication of the calculation, but it would be a conversation that would have to be had. But and my point in saying penny wise and pound foolish is I would be cautious to let that tail wag the dog, in as much as I'm not going to say I'm going to hold back on my facility increase because that's going to drive up my total spend, because I only expect to see pennies on the dollar of that savings on the back end. So that's kind of how I look at it, is find a way to allow the value-based side to be neutralized for the negotiation on the hospital side.
Got it. Thanks for walking through that. We do have one quick clarifying question back on the parity slide of just what that yield percentage is intended to represent.
Yeah, the yield was as a percentage of charges. So, and
Okay.
of course, too revealing, since any provider can set their charges wherever they want, but it's a good benchmark against others. So that was the payment to charge ratio.
Got it. Thanks for that clarification.
And then the size of the circle was relevant to their market share. So the bigger the circle, the bigger the market share they had in terms of revenue.
Got it. We also had one earlier comment about provider implementing Epic's AI denial solution. Are you familiar with that? Are you working closely with that?
Not familiar with that. No, I'm going to have to educate myself on that. I'm quite familiar though with Epic Payer Platform and how that can actually, and we're actually very excited about it. I know originally we, and rightfully so, we're all very concerned and maybe even paranoid about letting the payers, take a look under the hood. Big Payer Platform, there are some modules that have some very promising opportunity. In fact, we have a few case studies for electronic medical prior auth and its ability to remove a lot of administrative burden, moving to touchless authorizations, accelerating the authorization process down to a few minutes from a few days, which then has downstream effects on our ability to get patients in, scheduled, and treated sooner. So it has actual promise on care and quality. So that's super exciting, aside from the fact that it'll take out a lot of administrative burden. Another one with Epic Payer Platform, there's the ADR, additional documents requested. As we all know, your number one first pass denial reason is request of information, medical records, itemized bills. That module has a lot of promise, and as much as it's going to allow the payers to go out and actually pull down medical records prospectively and review them and then make their claim determination, rather than issue a RFI denial, which we then have to fulfill, adds 30 days at least to the process. Just wait for them to deny, we get the record, upload it, the cost, all of that. So I'm not familiar in the AI with Epic, but we certainly have access to the SME. So I will brush up on that. But Epic Payer Platform is one that I am encouraged by, and I would encourage other providers to explore it because it's new and it's still somewhat uncharted in terms of setting the rules of engagement. And so, first act kind of will have I think the most say in how that shapes up.
Hmm. Okay, great. Yeah, that does sound actually really exciting. Something I need to educate myself further on.
Yeah, there's a lot of payers leading the charge on Epic Payer
Yeah.
Platform. They've made a lot of investment, and so if they're putting their money there, they're motivated to
Hmm.
through. So I think that there's a lot of opportunity for us to just gain mutual value based on their motivation. We can leverage that and get what we need.
Hmm. Yeah, yeah, exactly. And I know we're coming up at the hour here. Maybe Brad, if you have any kind of parting thoughts or words of wisdom as we head out for the day.
Yeah, sure. I mean, I wouldn't pass on the opportunity to give my usual pitch. So, what gets me riled up is Medicare Advantage.
Hmm.
We providers, we see like 90% of the Medicare equivalent rate. After all the denials are said and done, the utilization management, pushing patients into observation when they would have been paid a DRG under traditional Medicare, that's very frustrating to me because on paper we're contracted at 100% or more with all these MA plans, but we actually see 90%, 90 cents on the dollar compared to a traditional Medicare patient. MA is getting bigger and bigger every year. And that's where, again, I think we really need to take an aggressive approach as an industry in terms of pushing back, putting a premium on the participation status by creating scarcity around it. And that's how we're going to reestablish leverage. But the way it's been is historically is the Medicare Advantage payers, with few exceptions, those who don't have a commercial product, let's say the Humana anymore. But with few exceptions, the way they pacify us is they continue to increase our commercial rates. And the commercial rates are no longer really sustainable, at least for self-funded employers. Commercial rates are 2.5 times Medicare. Your commercial population are the lowest cost to treat in terms of a patient population. They're younger than a Medicare population. We're getting paid 2.5 times on the dollar than we do for Medicare patients. And it's because the buyer, the spender, is a self-funded employer. So it's easy for the payer to spend self-funded employer dollars. And so again, when we come at them with issues about MA yield and what we're getting on the MA product, we're pacified by giving rate increases on the commercial. And it's our self-funded employers that are footing that bill. And that is not a sustainable situation at all. So we need to shift it back to the payers and not let the self-funded employers subsidize their profits any longer. So appreciate you giving me the floor to just kind of make that closing plea, but that's a battle that I'm taking on and I'm encouraging our clients to take on, and I would encourage you all to do the same.
Yeah, thanks for joining us for this hour, Brad. Enlightening discussion for me, and I think just based on the chat, it sounds like everyone else has enjoyed this. So I again appreciate you taking the time to walk us through this and share your thoughts. All right, thanks everyone for joining. I'm going to close out the session, but again, thanks for joining. Have a great rest of the day.